This Works webinar, part 2 of our Men's Health series featuring Dr. Brandon Lundell. In part 1, we covered the male hormonal crisis demystified, and today part 2 entitled Treatment Strategies for Male Health and Fertility. I'm Sally Lynch, VP of Marketing at Biotics Research Corporation. Before we begin, just a quick reminder, all of our webinars are recorded and posted to the Biotics Research website within 24 hours. If you have questions during the presentation, please type them into the Q&A box, and we'll address as many as possible at the end of the session. We're very excited to have Dr. Lundell with us again today. He has been practicing and teaching integrative and functional medicine for over 2 decades. His approach empowers patients by uncovering the cellular, dietary, and lifestyle origins of chronic disease. Using advanced laboratory medicine, thorough physical examination, and detailed patient history, he identifies exactly what is happening in the body and why, not just matching protocols to symptoms. His guiding principle is simple: good doctors know what to do, great doctors know why. That philosophy drives both Dr. Lundell's clinical practice and his teaching. He's the founder of the Nutritional Pathology Institute, has trained over 1,000 licensed healthcare practitioners through his certification program in functional medicine, which he'll talk more about. He has served as adjunct professor at Southern California University of Health Sciences and teaches for several organizations throughout the country, including the Council on Diagnosis and Internal Disorders. His work has been published in peer-reviewed publications and health periodicals. Dr. Lundell also serves as clinical service advisor and product formulator for the professional nutraceutical industry, formulations used in practices worldwide. Welcome, Dr. Lundell. Thank you for joining us today.
Yeah, thank you, Sally, and thank you, Biotics, for hosting this Men's Health webinar series. This is part 2. If you missed part 1, don't worry, it's recorded, and you can get access to it on the Biotics website, or you can go to my website, drbrandonlundell.com, or you can go to my YouTube channel. I have a YouTube channel as well, so just all of my free webinars are posted there, and I've got a lot of good resources for both patients and for doctors out there. So lots of ways to learn. So thanks Sally, and thanks Dr. Data. We'll begin because we have a lot to cover in part 2. So standard disclaimer here, just use this information, common sense. Review from part 1. Again, the recording is available. We went through functional endocrinology 101. It's kind of, 9 steps of the hormone journey. Traditional endocrinology and even functional endocrinology that a lot of people are practicing today, it's just looking at blood levels and then giving replacement hormones for that. That is not functional medicine, and it needs to stop. The madness needs to stop. And so that's kind of the main objective today, is to help practitioners understand that there are different ways than just TRT. So we have the production of the hormone and transport of the hormone and sexual hormone binding globulin, pre-receptor, receptor, post-receptor. All of that is part of what functional medicine addresses to optimize hormonal function, not just changing blood levels or urine levels or saliva levels. We talked about the testosterone crisis and what it is, the sperm and fertility collapse. What are the root causes of phthalates and BPA and fossil fuels and all of that, and endocrine disruption in utero as well. So we're seeing this transgenerational. The men today, young men today, are the product of what the generations before have done and been exposed to. So it's not just what happens today or what happened today, but what's been happening for the last 75 years. We talked about N-acetylcysteine specifically and how it supports sperm production and glutathione. We talked about the gut gonadal axis, the gelding theory, how gut endotoxin suppresses Leydig cell function, and the estrobolome and metabolome and all of that. And that becomes a really important clinical point of leverage. It's what we can do to support not just testosterone levels, but both male and female, the gut gonadal axis. I'll actually be speaking more on this weekend. If you're not registered, I've got an all-day teleseminar that I'm doing this Saturday, March 28th, and we'll be going more into fertility with both male and female. So today we're going to be focusing on the male, but there's so much to talk about with both male and female. We talked about SPMs, completing the resolution phase. We'll talk a little bit more about that. Butyrate as well. Those are all in the notes from part 1. So for part 2, we're really just going to go into treatment options. We laid the foundation of what the problem is. We talked about a few interventions. Now we're really going to get down and dirty into what we can do about it, and we'll go into a case study so I can demonstrate exactly what this means on a day-to-day basis. What do you do with your patient that walks in and says, we're having trouble conceiving, and 50% of conception problems for infertility is the male, and still lots of males are the second to get looked at. Everyone kind of focuses on the female, but when half of the problem is the male, that it should be addressed at the same time. Also, it's not about infertility and treating infertility. It's also about supporting optimal fetal development, optimal, DNA data getting transferred to the egg, making the environment optimal. So even if you're healthy, you can benefit from everything that we're doing. And in fact, that's the fastest growing segment of male support, for both supplements and diet and lifestyle. It's healthy males saying, you know what, I get it. I can't just do what I normally do and expect to have a healthy baby. There are things that we can do to avoid and greatly reduce the risk of things like ADD and ADHD and autism in our offspring. And not only that, these things that we'll go through today, all of them have been proven to increase the IQ of the offspring and increase the the health and the athletic ability of the offspring. So who doesn't want to optimize their children? And that's really what my passion is about, is not just fertility, not just creating a successful pregnancy, full-term pregnancy, but really optimizing our kids, because they're going to need it, right? This day and age has a lot of challenges. Couple follow-up questions that I thought were good to answer. I have a client who does not feel well if she takes N-acetylcysteine. She becomes quite ill when she receives IV glutathione. Why would someone respond poorly to NAC, and is there an alternative? Well, usually when I see that, it's a couple different things. Could be one or all of these. The first is often a CBS or a SUOX SNP. SUOX is a sulfite oxidase enzyme that breaks down sulfur-containing amino acids. That can be fixed oftentimes with a molybdenum supplement. So Mozyme from Biotics. Molybdenum deficiency is actually more common than you think. I check my nutritional deficiencies either through the NutriVal test from Genova or the Nutristat from US Biotech, which we'll go through today. Checking these deficiencies, this is why it's so important to make sure that the cellular machinery is supported before you even if you're thinking about giving testosterone. You've got to make sure the cellular machinery is supported. If it's a CBS upregulation, downregulation is more common, but if it's CBS upregulation, means that N-acetylcysteine is getting shunted into glutathione really fast. And that's B2, just supporting that with B6 and B2. And again, the SUOX gene is really important. Sometimes it's just the person's really toxic and they've been deficient in their methylation, not glutathione, but methylation processes. So support the liver, do SAMe. A lot of times I co-treat with SAMe. I almost never have anyone have a reaction to SAMe. And SAMe is another sulfur-containing amino acid. But even if they have a SUOX gene, the methylation support with SAMe takes care of that. It really supports the gene function. And of course, methyl donors, the methylfolate, methylfolate plus, or from Biotics, or B12 sublingual. So heavy metal burden, I often see that in heavy metal burden, a toxic burden. They may need some chelation therapy. Doesn't have to be IV, but a lot of liver support. I do a suppository chelation with EDTA, and that's shown to be just as effective. Takes a little bit longer than IV chelation, but if anyone's interested in my chelation protocol, tune in this weekend. I'll go through my chelation protocol, and there's a lot of great information we'll go over. The other thing that people don't realize is sometimes N-acetylcysteine and glutathione can release histamine. in a normal individual, that's not a big deal. It's only if you have a lot of histamine running around and you react to that histamine. So lots of quercetin, green tea, the bio FCTS, berberine to treat that along with the N-acetylcysteine. So give that along with the N-acetylcysteine. And finally, sometimes you just get oxidized glutathione accumulation, and that's often, and if that's the cause of their reaction, that's an NAD/pH deficiency, mitochondrial upregulation, so more riboflavin, more niacin to support that. So a lot of times this kind of goes back to, there's overmethylation problems. That actually there isn't an established, proven case of overmethylation. That's actually a biochemical myth. Now, there's imbalanced methylation for sure, where you're triggering more detox than your downstream enzymes can handle. So, don't just give methylfolate, or, it's usually a SAMe deficiency. Even when you give methyl donors, your body doesn't make SAMe, or there's a drain in the SAMe. So in that case, give also phosphatidylcholine. 60% of methyl donors go to production of phosphatidylcholine. And so the phosphatidylcholine biotics is great. I have a lot of my patients on that. It serves several purposes. One, it helps absorb other nutrients, because phosphatidylcholine is an emulsifier. So you get better absorption with quercetin, and better absorption with berberine, better absorption with curcumin, just by taking the phosphatidylcholine along with it. But it also supports methylation and increases endogenous SAMe. So yeah, great question. I wanted to address it because it's pretty central to what we do in functional medicine, and a lot of people don't quite get that correctly. So another question for patients who take SSRIs and other meds that impact hormonal levels, like testosterone or prolactin, what's your approach? That's, I usually run a neurotransmitter test to assess that, just to make sure that the neurotransmitters and the enzymes like the MAOs or those enzyme systems are supported well. This particular patient from this practitioner said that significant constipation that isn't very responsive to standard laxatives, protocol for the gut gonadal connection. I do have a protocol for the dysbiosis, and how I treat dysbiosis is usually some kind of dysbiosis issue when I see this. And yeah, I do have a gut repair protocol as well as a dysbiosis protocol. So if you're interested in the dysbiosis protocol, just go to my website, Dr. Brandon Lindell, and ask for that through my contact form, and be happy to give you that. But if you want more in depth of how we treat leaky gut and stool testing, that's this weekend. I'm going to go into how to read stool tests, which stool tests out there are supportive and effective, and which actually aren't. And some stool tests out there give you a lot of information that is inaccurate and really not clinically relevant. So we'll go through the case study today, talking about stool testing and neurotransmitter testing. What labs do I like to use to check for oxidative stress? Because that is, oxidative stress and DNA damage is ultimately the main mechanism by which our sperm get damaged, and they don't do well, not fertile. So things like lipid peroxidase and 8-hydroxy-2-deoxyguanosine. I use Nutristat from US Biotech and Nutraval from Genova. So, and then finally, what someone asked, I mentioned in that talk about a timetable of when you take supplements throughout the day. It is so important to know how to take and how to give your patients the right support in taking supplements. And a lot of practitioners don't do that. And if they don't, then patients are kind of left to just figure it out on their own. Usually, most supplements require 2-a-day dosing, BID dosing, because you want to increase the area under the curve. And most patients, most doctors, they just say take 2 a day or take 3 a day, or so they're going to load up in the supplements in the morning or sometimes right before bed because they forget about it all day. if we're going to do nutraceutical supplementation correctly, you want to know how to do it, what the research says about therapeutic levels and how to dose it and timing. So if you go to my YouTube channel, I have a supplemental definitive guide. It's about an hour talk explaining how to dose and how to take supplements. So really important for everyone. And I even have my patients watch it so that they can understand how to take supplements. If you're going to spend hundreds of dollars a month, thousands of dollars a month in some cases, you want to make sure you're doing it correctly and you're getting the most out of it. I always say this: supplements work better in the body than in the bottle. So just taking it is better than, oh, I didn't do it 10 minutes before, so I'm not a meal, so I'm not going to take it. No, it always works better in the body than in the bottle. So just encourage your patients to take it, even if it's not perfect. But to give them a good, well thought out regimen is going to increase your success as a practitioner and increase compliance as a patient. So there you go. That's the supplement video guide. All right. So can you pick out which one needs antioxidants and methylation support? Probably pretty obvious. Yeah. These days, it's actually reverse. 3/4 of sperm are under oxidative stress. 20 years ago, 30 years ago, it was only a quarter. Already in just 20, 25 years now, 3/4 of sperm are shown to be under severe oxidative stress. This is actually a really good article. I'm not going to go through it too much, but this is an article in GQ, Meet the People Fighting the Crisis in Sperm. It was last year. And yeah, it's a really good article just explaining what we're dealing with. I thought this was interesting. There's actually no male equivalent to gynecology, and there really should be, right? An andrologist, and that's many attempts have been made, but guys are kind of traditionally, they just ignore their bodies until it's too late. And so, being an andrologist, you're like, waiting for that one guy to go, hey, maybe I shouldn't be, bleeding out of my, orifices. Maybe I should go see somebody. So that's changing. And I think andrology should be more of a focus. Because right now it's pretty meager what male health gets. You go see a urologist. Urologists have taken on the andrology, and that's pretty poor because they don't get any training in hormones, just prostate and bladder and stuff. So we know 50% of fertility problems are attributable to men. Talking about the shame and ignorance as part of the real crisis as well. Shauna Swan, I talked about the countdown. This article talks about Shauna Swan. She's been the biggest proponent of, hey, look, the main cause here is fossil fuel, chemical industry, the phthalates, BPA, and at current rates, the consensus is most couples will need assisted reproduction like IVF or, IVI or things within just 20 years. Already, almost half of couples need it within 20 years, most, if not all couples, unless we change it now and unless we offer these kinds of therapies to our patients as standard of care. It should be standard of care. So that's my mission, is to make this kind of stuff standard of care for both men and women. We're talking about men now, but as I said, I'll be talking about both men and women this weekend. Whole genome embryo screening. There's just lots of things on the horizon where you can screen your genome, and you can choose your designer babies. And Y sperm is the most one of the most susceptible cells in the entire body. It's a single cell. It's 100 million sperm a day. It's very active. It's a short half-life. Very much susceptible. The most susceptible cells in the human body. Both males and females, to oxidative stress. So, going out and having a couple of, scotches, every night, you're completely damaging your sperm. The other thing interesting here is cannabis. Most studies show a 33% sperm reduction with even 1 or 2 times a week use of cannabis. You translate that to every day, and of course you get the increase in sex hormone binding globulin, which lowers testosterone. You also get an increase in estrogens, with both males and females with cannabis use. So there's a lot of problems with that. Not talking about morally, just whatever, whatever you want to do in your free time is fine, but just understanding that, yeah, if you're, just like drinking alcohol, there's things that you probably want to do to protect yourself if you're going to do that kind of stuff. So, all right. And also, sperm quality is really just another marker of systemic health. So if your sperm are damaged, it's just a symptom of your body being unhealthy in general. So a lot of interesting things on the horizon. So let's start part 2 here. What are the treatment options? What do we do with testosterone dysfunction? I won't be able to get through all of these slides. I will get through all of them this weekend. I've got about an hour and a half slated to go through male and female hormones. But if you want these notes, you can, again, go to my website, Dr. Brandon Lindell, and just submit a request, and we'll be happy to give you these notes. But we're going to go through it pretty fast. The conventional medical approach, as we know, to most male hormonal problems and it's getting more and more common in younger generations, people in their 20s and 30s being put on TRT. And while TRT might relieve symptoms, it typically does not address the underlying reasons for why they need it in the first place. Low testosterone is a symptom, not a disease. It's not a disease to be treated with testosterone. It's a harbinger. It's saying, hey, there's other things going on in the body that need to be addressed. So resolve what those are: inflammation, insulin resistance, chronic stress, sleep issues, environmental toxins, and nutrient deficiencies, all of those things that we talked about. So reliance on external testosterone suppresses the HPG axis in every single time, and that creates more hypogonadism and lower pituitary function in every single case. LH and FSH drops, gonadal tissue shrinks, and it's almost impossible to get off. It's not impossible, but it feels impossible if you don't do this kind of stuff that we're doing today. And man, it is an industry, and it's a growing industry, and they are good at selling, right? They are good at selling this stuff. Even at A4M conferences and IFM conferences, man, oh man, somehow hormone replacement therapy became linked with functional medicine. It is not functional medicine, folks. TRT and hormone replacement therapy has its place, but it is not functional medicine. Functional medicine is hormone restoration, not hormone replacement. Any type of treatment that forces you to rely on a drug or an exogenous pharmaceutical is not functional medicine. So just to be clear, and I'm not against HRT when it's necessary, but usually you have an entrance and an exit plan. Okay, we're going to do this for a short period of time while we do these other things, and then here's the plan to get you off of it, which, by the way, should be how all medications are prescribed. Here's why we're doing it. Here's the reasons why you need it. Here's, the underlying causes that we're going to treat, and here's the timeline. If you do these things, we'll get you off of it. No one ever does that in traditional medicine, unfortunately. So really, is it the only answer? Well, again, it's there is a better way if we know it. Yeah, it takes a little more effort by both the doctor and the patient, right? It's a lot easier to spend 5 minutes with the patient and say, oh yeah, your testosterone's at 230 and your free testosterone's at 1.2. So yeah, here you go. Here's your prescription, and you might feel better for a few months. Everybody gives themselves a pat on the back. This is great medicine. And meanwhile, there are significant risks that go ignored in most cases. So first off, if you're doing any kind of shot or troche, pellets are a little bit better, gels are a little bit better, but you're getting this abnormal spiking of your testosterone, especially with IM, and it's not normal to have 1,600, 2,000, and then within a few days it's back down to 0 or 200, and then up and down and up and down and up and down, and that's very, very hard on the cellular mechanisms. It's hard on the brain, it's hard on the testes, it's hard on the sperm. This is not a normal, natural diurnal curve by any means. Most the diurnal curve, most males testosterone only is in the morning it's the highest around 800, and in the evening it might be around 600. So you're only getting about a 200 nanogram per deciliter change within the day, 250 on average. So this is, on average here, you're getting within a day or two, 1,600 nanograms difference. So long-term dangers, we know there's receptor downregulation. Chronic exposure to high levels create downregulation of not only the receptors themselves, so you become testosterone resistant, and every single male and female that I've seen on testosterone is actually testosterone resistant because you're giving super physiological amounts, and the cells will protect themselves and downregulate the receptors, which creates what? It creates more dependency, because you feel good at first. You're like, yeah, I really did feel a difference. And then after a couple months, you're like, I don't really feel a difference. Guess what the answer is in most cases? Oh, just take more. All right, I'm going to take more. And then to make matters worse, you're only looking at the blood, which is not showing where all of that testosterone, being a fat soluble hormone, is being actually stored. So we'll get to that in a second as well. We have convergence to estrogens. They're getting better at that with, giving aromatase inhibitors, but those aromatase inhibitors also are hard on the liver. They're hard on the HPA axis. It's not, it's not the answer. So elevated liver enzymes we see almost all the time. Elevated testosterone is very, very hard on the liver for both males and females. And we have a lot of other problems as well, which we'll get to. But there's a limitation in blood testing for monitoring exogenous hormones, and it is exactly what I just said. When you give parenteral hormones, whether it's cream, whether it's shot, whether it's a troche pellet, the hormones are traveling through the lymph system. Yes, they do get into the blood, but they usually then get onto the red blood cell and not through sex hormone binding globulin, and so it's not detected. Levels increase in the tissues, so you can't rely on urine or blood. And every single practitioner I know out there, and I want to just scream it, like, get a clue. You cannot just run blood and urine tests to test for levels and treatment effectiveness, because in almost every case, the tissues are rising and rising and rising in the tissue levels. So, so the only way to really look at tissue levels is saliva testing. And doing both gives you a good, accurate picture of what's being produced, what's being, in circulation in the blood, and what's actually accumulating in the tissues. The half-life of testosterone in the tissues, it can be weeks, because it's a fat soluble hormone. It could be even months. Where does it go? And it's even worse if you have a lot of fatty tissue, if you're overweight, because all of those hormones get stored into fat tissue, and they don't get broken down by the enzymes that exist in the blood and inside the cell. So they accumulate and they slowly get released. And I've seen people get off of shots, injections of testosterone, and their saliva levels are still extremely elevated, 10, 20 times higher than normal, months after they stop the injection. But the blood levels return to normal within days, within hours, within days. So you can't rely on blood testing. That's one of the main things I want to just, if you get nothing else out of today, you're welcome. My job has been successful. You have to look at saliva testing if you're going to be, and saliva testing has its issues. I mean, it's not a perfect, measure. I mean, the perfect measure would be taking tissue biopsies, but that's not really viable. So the next thing we have is, the next best thing we have is saliva testing. So, but know that if you are giving exogenous, or a patient's taking exogenous, blood levels aren't really actually what the cells, it's not reflecting what the cells are being exposed to. So in this study, increased risk of non-fatal myocardial infarction. I know this is controversial, and every study can be broken down and ripped apart. My point today is to not get nitty-gritty into, well, this said that and this said that, and but this doctor says this, and that. I have this conversation with just about one patient a day who's like, well, but my endocrinologist or my other functional medicine doctor said that, you know, testosterone is protective for breast cancer. I'm actually going to debunk that myth this weekend. Testosterone for women is not protective for breast cancer, not as protective as most people think. So I'm going to stir the pot a little bit. This is, I've got the data and I've got the science, and I know everyone says that, but I know that this is true, and I want people to see this, because where the trend is going is not good. I just treated a patient yesterday who had a blood clot from too much testosterone, you know, and that was the cause. And you know, even the emergency room was like, we're seeing this more and more. We're seeing men shoot up testosterone and then they get a blood clot, you know, and sometimes it is deadly, you know. Now here, this is non-fatal, an increase in non-fatal. So usually testosterone therapy increases non-fatal myocardial infarction. Okay, that's better, but you're still getting a heart attack. You're still getting you know, issues with that. Now, low testosterone also, please, I am not saying that the testosterone crisis isn't real and that testosterone therapy hasn't been helpful, but there's a better way. And the testosterone prescriptions need to, you know, need to stop here as much as what is being done. Testosterone treatment in coronary artery plaque volume. Yes, non-calcified plaque significantly increased in the testosterone group. Total plaque volume also increased. Now, low testosterone also increases plaque. So what we're saying here is low testosterone is a problem, but exogenous testosterone also has its own issues. Then this is an often cited study. Oh, cardiovascular risk with prolonged elevated testosterone. And we saw that, hey, the transdermal testosterone was much safer actually, because you're not getting those spikes that we talked about. And this was, you know, a almost 2-year study, so it was, you know, not a bad study. So the primary major coronary artery endpoint, you know, was essentially the same, right? Okay, so yay, the cardiovascular risk with prolonged elevated testosterone therapy is about the same. That's the headline. That's what everybody saw. But when you actually read the study, okay, there's some caveats here. Atrial fibrillation increased in the testosterone group. Acute kidney injury increased. Pulmonary embolism increased. Coronary artery calcification increased. There was also a 60% dropout rate because TRT was, you know, they either couldn't do it or it caused other problems. Erythrocytosis is also another thing that we see all the time, which increases the risk for clotting and strokes. So we do have risks that we need to understand. Also, emerging research is showing that testosterone therapy, actually, you know, exogenous high doses, how can you not have other side effects when you're getting super physiological doses? The tissues are experiencing 3 to 10 times the level of testosterone that a normal healthy male would experience. All the while, most of these men still have oxidative stress, they still have insulin resistance, they still have nutritional deficiencies. All of the problems are still there, which actually testosterone therapy makes worse. So, if I'm not sufficiently on my soapbox now, I will, you know, digress a little bit. But testosterone, there's some research showing that it even promotes cancers and glioblastomas. So you get to choose. You get the exogenous TRT, which causes HPG axis shutdown, erythrocytosis, cardiovascular damage, gonadal atrophy, fertility destruction, prostate and cancer risk, sleep apnea worsening, hepatic enzyme, all this lifelong pharmaceutical dependence. Okay, that's one way to normal testosterone levels. Actually, it's too high, or we can do the functional endocrinology route, right? We can do HPG axis restoration through, you know, adrenals and healthy gut microbiome, the gut gonadal connection, cardiovascular resolution through decrease in inflammation, and homocysteine and methylation, weight loss, fertility, preserved mitochondrial function is restored, which, remember, hormones are made in the endoplasmic reticulum and it needs mitochondrial functioning. So I find that most males and females who don't have good egg or sperm quality, or mitochondrial axis is huge there. Sleep architecture, hepatic detoxification support, better brain, mood, health. Yeah, so you get to choose which way you want. I'm advocating for the second route here. So we all know this. I'm going to go through this pretty quickly. Anti-inflammatory diet. My anti-inflammatory diet, in the beginning, there's a healing phase and then a more maintenance phase. Gluten, dairy, sugar, alcohol free. You got to remove those things in order to help the leaky gut heal. There's just no way around it. Usually about 3 to 4 months, we have patients reduce all of that stuff. So you can go to my website. I've got my anti-inflammatory diet for sale. It's only $99. It's a 2-hour course, and I have my patients take it and listen to it. And it talks about how to form the diet. I had a professional chef take my anti-inflammatory diet and make a cookbook out of it. It's called The Heartful Kitchen. So there's a lot of good recipes in The Heartful Kitchen by Maria Cooper. So you can go on Amazon and get that. I don't get any money from it, but I just get the satisfaction of tasty recipes. And then of course supplementation as well. So one of the big leverage points is your stress, autonomic nervous system, HPA axis dysfunction. Chiropractors out there really good at adjusting and taking the stress off of the nervous system. Chronic stress activates the HPA axis. I think it's often missed. It's never addressed in TRT therapy, but elevated cortisol levels suppresses the HPG axis. I actually read a study that looked at testosterone levels and cortisol levels, and the most damaging to sperm and testosterone function wasn't testosterone levels, it was cortisol levels. So the higher the cortisol levels, or the imbalance of cortisol levels, the more problems. Now, then you get adrenal dysfunction, you get adrenal failure, and low cortisol, because cortisol can potentiate testosterone. And so if you get unopposed testosterone from cortisol, that's one of the reasons why you're seeing so much inflammation and heart disease and heart attacks with testosterone therapy, because the adrenals and the cortisol levels are actually too low in some cases. So, so poor quality sleep is a big issue with that. So low melatonin levels, almost all males over 50 that I've treated with low testosterone production have low melatonin, and so melatonin becomes a really good point of leverage for restoring. And there's many studies that I have. I don't have time to go through them all today, but melatonin can help restore testosterone levels. Very helpful for the sperm as well, because melatonin is a very potent antioxidant. Most people don't know this, but the gut secretes 400 times more melatonin than the pineal gland. And melatonin becomes a really important treatment for leaky gut in my practice. These are two really important ones in my sleep stack for patients. This is the new one, Sleep Tides, the Pepti Sleep. I've been using it myself and in my patients for a couple months now, and it really does work. You get more sleep. You wake up feeling more refreshed. And if you combine it, a lot of people don't do SPMs at night, but man, I do vitamin C at night. I do SPM at night. I do a little bit of N-acetylcysteine and Sleep Tides. So it's a pretty powerful, sleep support formula there. And not only that, but all of those support the antioxidant and glutathione processes at night that are so important, and it preserves melatonin levels. So Sleep Tides, we'll go into that this weekend. So again, if you can't make it, sign up. It'll be recorded. Just sign up and purchase the recording, and you can watch it at any time. But go ahead and sign up. Go to drbrandonlundell.com and go under my courses, and you'll see that. So please sign up for that this weekend. And we'll go into the sleep and what Sleep Tides does. It actually does many things, like phosphatidylserine. It lowers cortisol levels. If cortisol levels are too high, it will not lower it if cortisol levels are normal. But phosphatidylserine can be a good part of the stack as well. So I'll go more into that this weekend. So hopefully you can join us there. Let's see. Just going to make sure we've got the time. Sally, if you want to let me know like 15 minutes before one, that'd be great.
Sure.
Okay, steroidogenesis happens in the mitochondria and endoplasmic reticulum. So antioxidants, things like alpha lipoic acid and grapeseed extract and N-acetylcysteine, these are really important. Mitochondrial density in gonadal tissue, the mitochondrial density is one of the most dense in gonadal tissue and adrenal tissue. So that's I think why vitamin C has been a mainstay of adrenal treatments. Before vitamin C was isolated and was able to be chemically produced, the treatment for vitamin C deficiency, scurvy, was actually giving the adrenal tissue to that patient, and that cured scurvy. Limes didn't cure scurvy. Limes prevented it, but limes don't have enough vitamin C to cure scurvy and other things. So the reason why that's important is because the body's highest concentration of antioxidants is in the gonadal tissue and adrenal tissue, which is why we'll talk about cytozyme orchic and cytozyme M. Highest amount of SOD and vitamin C in gonadal and adrenal tissue, which is why if you're deficient in those things, those tissues get burned up very, very quickly. So testosterone promotes more mitochondrial biogenesis. So you get this feed forward loop or this down regulation where mitochondria starts to decrease, the testosterone starts to decrease, and then testosterone isn't promoting mitochondrial biogenesis and on it goes. So when testosterone levels decline, mitochondrial function diminishes, impairing the cellular energy, and that's the loop, especially these star protein expressions, which we'll get to, which actually is one of the things that the sleep peptides support. The sleep peptides support the star protein expression, and that helps steroidogenic acute, regulatory promotion. So that's one of the reasons why I like the sleep peptides as well. So pretty powerful stuff. Oxidative stress is a major contributor to Leydig cell dysfunction. We already know that, so we'll go through that. Lipoic acid, I mean, it's a mainstay in my practice. And some of the research shows, you need 600 to even 1200 milligrams, but if you are combining it with things like vitamin C here in the lipoic acid plus, you're combining it with CoQ10, if you're combining it with vitamin C, if you're combining it with phosphatidylcholine, then that all, and N-acetylcysteine, together you're preserving that lipoic acid, so you don't need as much. When we look at studies that look at just a single ingredient like lipoic acid, yeah, most of the studies use a dose of 600 milligrams, which isn't hard to achieve, but very few studies, in fact none, very few, maybe one or two out there, look at, okay, well, what if we add N-acetylcysteine to that? Oh shoot, well then actually the therapeutic dose goes down of what you need for lipoic acid. So it's kind of synergy only goes so far, but it does help a lot when you're creating a nutraceutical regimen for your patients. But alpha lipoic acid on asthenozoospermic patients, that means that the sperm isn't going, moving really well. It's low motility. ALA works in both aqueous and lipid phases. One of the strongest human randomized control trials for any single antioxidant in male fertility. All sperm parameters improved. Production, semen production, sperm production, DNA oxidation went down. All of those parameters improved with alpha lipoic acid. So CoQ10 is also one of my favorite. Positive correlation between treatment duration and improvement. So the longer you're on CoQ10, remember it takes about 6 months, well, 3 to 6 months for sperm to be fully matured. So it does take about 3 months to see the end result benefit. So those little sperm that are shooting out, going to be your child, it's what you were doing 3 months ago that did the damage. So I always recommend a minimum of 3 months when I do preconception planning, and we'll go through that this weekend. Minimum of 3 months, both for males and females. So, but that's one of the reasons why. So CoQ10 is one of my favorite. And then again, you combine them, pretty powerful. So the research individually is 300 milligrams a day, increase testosterone by 30%, 600 milligrams a day by itself increases fertility and testosterone levels. When you combine them, you probably don't need, usually what I do is 200 milligrams minimum of CoQ10 and 400 milligrams minimum of alpha lipoic acid if you're combining them. Another one of my favorites is B Vital, and that is Peruvian maca, high concentration, just one cap has 750 milligrams. And the thing that I like about biotics, the thing that I love about biotics and rely on biotics is their level of testing and everything that they do. If you haven't had a chance to go down and look at their facility, it's pretty amazing. And I'm a nerd and I love the production of these things and sourcing and the testing and the assays. They really, they reject more raw materials than any supplement manufacturer probably in the world. I mean, if it's not up to standard, they reject it. And they don't just take the certificate of analysis that the manufacturer supplies. They test it themselves with probably one of the most advanced, certificate of analysis labs out there. So it's pretty amazing. And then they add velvet deer antler from living elk, and where it's living elk, they don't kill it. We have a lot of elk in Colorado, and I had I lived in Lyons. I lived in the mountains for several years, and every year I would get these huge deer, elk antlers and deer antlers. So it was pretty cool. This study
15
here.
minute mark. Just
Okay,
saying,
great.
yeah.
Gosh, 15 minutes goes fast, doesn't it? Or an hour goes fast. So in this study, 1,500 milligrams versus 3,000 milligrams, basically it was about the same. So you only need 1,500 milligrams. And serum, the thing about here is serum testosterone did not change, yet every function, every marker of sexual and testosterone function increased. This is functional endocrinology, everyone. This is, you're not just because it doesn't affect the testosterone levels, it's affecting insulin receptors, it's affecting testosterone receptors, it's affecting the cellular machinery. Maca increases antioxidant production inside the cells. So there's a lot of different mechanisms that we want to, remember. Functional endocrinology is 9 different therapeutic endpoints, not just one, which is the blood or serum levels. Maca improves sexual desire independent of testosterone. So I'll go through these pretty fast. These will all be in the notes. I want to get to the case study here. So I'm going to just skip ahead to the case study. So I do like Cytozyme Orchic. It's absolutely one of my favorite. You've got the bovine orchic concentrate, which is testicles, and they do it from neonatal glandular concentrates, which has more testosterone and it has more antioxidants. It's not from an old cow that's been sitting in its own poop for a year and eating grass or eating corn and getting inflamed and doesn't have any testosterone left, because that's what happens with most but this is with most bulls. But this is orchic concentrate from neonatal tissue. Cytozyme M also has orchic concentrate, a little less at 40 milligrams versus 180, but you also have adrenal complex, thymus, spleen, to help the whole HPAG axis, which that can be very, very helpful. You do need more of this. So my typical dose for Cytozyme Orchic is 4 tabs. They're small tabs, 4 tabs twice a day. If I'm going to do Cytozyme M, I'll probably do 6 tabs twice a day in the beginning. So pretty amazing about the oral tolerance. It decreases the antibodies to gonadal tissue. Fish oils, just an incredible 21% increase in semen volume and testicular size and FSH and LH levels. So omega-3s are really important. Here's the SPMs that I like. All of this we're going to go into more this weekend. This is my weekend stack here. So I knew I was not going to get through all of it today. I only have an hour, but one that I want to focus on just for a few minutes is grape seed extract, because it's very misunderstood. A lot of people think that dinomethane is an aromatase inhibitor. It is not, and in some cases, it can actually increase aromatase. But grapeseed extract is it's better than chrysin, and it's one of the best aromatase inhibitors we know of. So the biocyanidins is my favorite, but that's a key mechanism. It's aromatase inhibitor. So if you are seeing elevated estrogens in males or females, grapeseed extract becomes one of my favorite. Not only is it an aromatase inhibitor, but it reduces oxidative stress. It's one of my absolute favorites in practice. I take it myself every day. So that biocyanidins it upregulates the STAR enzyme that I was telling you about as well, which is the steroidogenesis. So directly upregulates steroidogenic enzymes. So and the other thing that's in biocyanidins is pycnogenol. So pycnogenol, interestingly, there's been some really good studies when you combine pycnogenol, grapeseed, and arginine. Blood testosterone levels increases significantly, cholesterol decreases, increases nitric oxide, which is necessary in spermatozoa and sperm production. So pycnogenol is pretty cool to combine that with the grapeseed extract. And then I add the L-arginine as part of my sperm stack, if you will, or sperm protocol. So pretty cool. And you can see just with arginine and pycnogenol for 4 months, you had a double the sperm concentration. So just with pycnogenol, and they only use 600 milligrams of arginine plus 60 milligrams of pycnogenol. So you're not talking about a lot there. So you can also get some more some more arginine and other citrulline and amino acids in the amino sport as well. So pretty cool stuff. So let's get into the case study real quick. I will go over this more in this weekend, as I said, but we have Chad here. That is actually his real name. I didn't I didn't choose that name. Chad in memes is kind of the viral man. So 35-year-old male, initially presented to me in March of 2024, low testosterone. He'd been on testosterone replacement therapy for a couple years. Was recently seeing another functional medicine doctor, chasing him, leading him down the mold path. Look, mold is an issue for some people, and it's not in a lot of people. And just because you find mold doesn't mean that it's a problem. That's a talk for another time. But so many people are wasting thousands of dollars chasing the mold fairy. It can be an issue, but it's not always an issue. So he started on testosterone replacement, 50 milligrams, 3 times a week. His testosterone was consistently above 1500, no FSH and LH, maybe exposure to Lyme disease. He did have some babesia. So that's kind of your root cause history of chronic infections. Epstein-Barr can play a role in all of this. He had elevated estradiol, even though he was on anastrozole. History of gastrointestinal issues currently, as well as in the past. But yeah, again, he spent thousands of dollars trying to treat mold. No better, no results. And so significant day-to-day variability and well-being, he described it as a roller coaster. Well, of course, the mimics the testosterone. Severe fatigue and energy fluctuations, brain fog, mood disturbances, digestive issues, couldn't exercise, sleep disturbances, all of that from testosterone. So here's his actual levels. He was low. He was a 35-year-old male with hypogonadism. There's no question about it, but he was only given testosterone as his main point of therapy. He was not giving any other options. So he had a blood test. He had some fecal eosinophil protein, so gut inflammation. So definitely the gut gonadal connection is at work here. And total short chain fatty acids were extremely low. His fecal zonulin was high. So no doubt that he had leaky gut and the gut gonadal connection. Bilirubin was high. His AST and ALT were starting to rise because of the testosterone. These are the labs that I ran. And his free testosterone is at 60% or 60 nanograms, 5%. and testosterone levels were consistently above 1200, and it was inconsistent, right? So if he would skip one, it would drop back down because he was hypogonadal. So he had iatrogenically induced hypogonadism. He had it before, and it got worse because of the therapy, because of the treatment. So we did the testing, like I said, we did the saliva testing, as I mentioned, that's so important. We did the stool analysis to evaluate the gut gonadal connection, and then we did your organic acid nutrient testing as well, vitamin B status testing, and finally the methylation profile. These are my standard tests, okay? These are the things like SpectraCell or NutriVal or the Nutristat. These are my standard tests that I run for, you know, almost all my patients, but definitely for males and females. His total protein was low, so it was starting to damage his liver. Testosterone was still extremely elevated. Estradiol was elevated, as we see here. Estradiol down here at 75, even on an anastrozole. And bilirubin continued to rise, so we had Gilbert syndrome. That is a real issue that needs to be addressed. That means his detoxification ability is low, so he needs more N-acetylcysteine and more support for the liver. His iron and transferrin was high. His ferritin was okay, but that's because he was actually internally bleeding from so much leaky gut. And he had probably mild celiac as well because the zonulin being so high. We can see his morning cortisol was almost nothing. And then the stress got his noon cortisol levels back up, but then it went back down. So very disrupted adrenal axis. His DHEA is definitely on the low side for a 35-year-old male. I typically like it above 250, 200, or 250 or 300. And sure enough, his testosterone is at 287. Now, don't be fooled. This is a doctor's data test. Yes, he was on testosterone therapy, and so it's in the green, but this is what a normal healthy male produces, 30 to 155, and he was at 287. So in my opinion, it's too high. It's sure within the dramatically high range of 95 to 800. Remember, in labs, all labs have to produce a population-based average, not an optimal. So even doctors' data and Genova and US Biotech, they can't produce a functional range. That's up to us as practitioners. So he took himself off testosterone when he started. I told him not to, but he's like, oh my gosh, we're gonna get started on all these things. This is great. He took himself off the testosterone, boom, and this is what happened. It went down to 222. And his testosterone, though, in his saliva was exact same day of the test. His testosterone is 222, and in the blood, and yet the saliva, the tissue levels were double what should be triple what should be in a normal healthy male, which should be about 100. So this is proof that the blood levels do not reflect tissue levels, and that the only thing that does that is the hormone or the saliva test. So, and again, this is another blood test that we did, is showing DHEA being low and sex hormone binding globulin being high. So, you know, that's grapeseed extract will help lower that as well, and is free testosterone. So this is just another blood test showing how imbalanced it was. This is a stool test. We'll go more into how to read this weekend. Again, if you can't make it, sign up and I'll give you the recording. He had Citrobacter, he had dysbiosis, he had Candida, he had the fecal calprotectin, all of that. So I'll share with you my dysbiosis protocol. If you want my dysbiosis protocol before Saturday, go ahead and email me. Go to drbrandonlundell.com and I'll give you my dysbiosis protocol. We usually adjust it based on the culture and sensitivity here. So we can see that caprylic acid, so the caprin biotics was really helpful. Olive leaf extract is really helpful, and colloidal silver. I use a lot of colloidal silver in my practice, especially for dysbiosis. It's very, very effective. And then these were what worked. The golden seal worked for the natural agents for the candida. So we have a good dysbiosis protocol of what's actually going to work, not just throwing a bunch of stuff at them, you know, and seeing if it works. I do find that ADP works for most people as well. Doctors Data used to test for, I guess they do test for oregano still. So if it's high, then you definitely want to use it. Sometimes I'll still use it because it's a great antioxidant in the gut as well. So here, lysozyme was elevated, so he had gut inflammation. All of this was what we were seeing. Remember what I talked about SAMe earlier? His level was in the bottom 1 percentile of all production of SAMe. There was no way, you can't produce hormones without SAMe, period. You just can't. And so SAMe became a really important point, and it was completely missed. His B12 levels were fine, his folate levels were fine, but he wasn't producing SAMe. So for a while, he needed the phosphatidylcholine and SAMe. These are organic acids. We'll go over organic acids this weekend. This was his food sensitivity test, value in IgG testing if you know how to interpret it. So we'll go through that. But this is his actual diagnosis. Remember, a good doctor knows what to do. I can give you a testosterone, protocol, but a great doctor knows why. Now you know why. Liver overload and leaky gut and the gut gonadal axis, micronutrient deficiencies, methylation disorders, chronic infections. This is then how we develop our treatment strategy, okay? And so, we gradually reduced his exogenous testosterone while we built him up. Usually it takes about, in general, I recommend every 2 weeks going down about 25 to 30%. Your own gonadal function needs, the patient's gonadal function needs time. The gut healing protocol, this all happened at the same time, even though we call it different phases. This all happened at the same time. Your adaptogens and your antioxidants and the nutrient deficiencies. So stress reduction, resistance training, the sleep, all of that, autonomic nervous system focus. I'll go through more this weekend of how we really do that. Temperature modulation, sauna followed by cold exposure or vice versa. That can be very helpful. It's very popular these days. So again, we adjusted the testosterone dosage, 25 milligrams, and then we just kind of slowly went down while adding, this was his nutraceutical intervention. Multivitamin, methylfolate, vitamin D, multimins, your probiotics, vitamin C, fish oils, phosphatidylcholine, CoQ10, the bio-FCTS for the antioxidants, and quercetin, N-acetylcysteine, alpha-lipoic acid, biocyanidins, and the aromatase inhibitor and pycnogenol, and then Caparest is the anti-inflammatory. Then we did some specific hormonal glandular support, DHEA, pregnenolone, cytozyme, Orchic, that kind of stuff. Now this may seem like a lot, and it is, but it works, and it's not forever. And so, if you put it plainly to your patient, hey, you can spend the next 5 years making yourself sicker and sicker on testosterone therapy, and then possibly getting cancer and being completely sterile and never having, kids, or you can spend a couple, $1,000 a month or whatever it is for 6 months, even a year. Most people will be like, yeah, sign me up. If this works, I'm going to do it. And what I can tell you, after being in practice for 20 years, this works. It works almost every single time when you make the right diagnosis, when you run the right tests, and you know exactly what to do for your patient. So this is not what I do for every patient. This is what he needed, based on the tests and based on his presentation. So we ended up, you can do these things. We didn't do it for him, not everything, but we did some milk thistle. You can do nicotinamide riboside. You can do ultravirex. You can do more acetyl L-carnitine. We definitely did the SAMe. I think that was in there. You can do an optional dysbiosis protocol, Caprin, ADP, dysbioside. I do a 10-day on antimicrobials and then a 4-day on probiotics. But a lot of times you'll want to heal the gut a little bit first, doing the glutamine, doing the N-acetylcysteine, doing your leaky gut. So within 6 months, we were able to wean him off all testosterone injections. His sperm counts were normal, normalized his endogenous testosterone, resolved his liver enzymes. experienced a significant boost in his energy, mood, libido, cognitive clarity, and all while not being dependent on the exogenous hormones. Now, this was 6 months later. This was off of all hormones for about 3 months. And his testosterone levels, we often see a rebound. And in this case, Chad, his rebound has stayed. His actual normal levels, now a year and a half later, we just tested him a couple months ago. It's still around 1,000, 1,100. That's his normal, healthy production. And he was hypogonadal before testosterone. So this works. It is a complete restoration of his normal HPAG axis. So pretty incredible. This is another 4 months, and he's got full autonomous production. So pretty incredible. I should put the one that we did just a month ago because it was like about 1,000. So, and I kept asking him, I'm like, are you sure you're not taking a little testosterone? I mean, it shouldn't be at like 1,100 a year and a half off of hormones, but that's his, he's still in kind of that rebound phase. So that is, that's how we do things. So a good doctor knows what to do, but a great doctor knows why. I'm here to teach you the why. So join me this weekend. We're going to look at peptides, and we're going to look at cardiovascular markers. We're going to look at GI stuff and fertility. It's a great test. It's a great day of learning. And I've got Dr. Brett Wisniewski joining me as well. Some of you know him. I also have a mentorship, and I'm starting a new mentorship cohort in April. This is one of my favorite things that I get to do. I get to work with doctors and practitioners one-on-one. And I've seen this, that a lot of you out there have a lot of knowledge. You've been to a lot of seminars, and you may have some certifications, but how to actually implement it in the way that I've taught you today, that takes some one-on-one mentorship a lot of times. That takes a little bit more know-how than just going to some seminars. So I developed a mentorship where we have a small group. It's a small cohort, around 12 to 15 docs for 6 months. We do a small group every other day or every other week, and we get together and we talk about cases and lab interpretation and practice building and all of that. But then you get me one-on-one every month where we go over what exactly you need. Where do you need more support? What's happening in your practice? We can go over your cases. We can go over your labs, and I tailor this mentorship program to you, what you need to thrive at the end of that 6 months. So we've got a few spots left. We've got a few spots for the April 9th. It's going to start April 9th on Thursday. And so I'll sign up today, because once it's filled up, I do cap it, because it's a lot of one-on-one time. Like, it's half hour, 45 minutes every time we talk, just one-on-one. If I've got 16 people in that class, it's just, I still have a practice to run and a family to be in. So we do cap it. So if you're interested, please sign up today. And these are all the things that you get. So that's, and also the cool thing about the mentorship program, Doctors Data gives us 2 free tests. So the cost is $3,500 for 6 months, which is in itself an amazing deal, but you get immediately $2,000 worth of free tests and products. So the cost of the program really is only about $1,500. It's insane. I don't know why. Usually I'll do multiple cohorts, but everyone should be taking it, in my opinion. You get 50% off of the US biotech tests, and you get a free stool test and hormone test for Doctors Data. You get a free LabCorp, a full panel, 200 different analytes. So pretty incredible at what you get in the mentorship. So I hope you can join us for that. So there you go. That's all I've got. Thank you, Sally. I don't know if we have any time, but.
Well, yeah, no, I think we're a little over, but thank you for this very informative presentation and all the information at the end. You're quite a resource. We did get quite a few questions, as we expected, and but you can email us at communications@bioticsresearch.com, or directly reach out to Dr. Lundell at drbrandonlundell.com to have your questions answered. Also, a couple of reminders. This webinar has been recorded and it will be available on our website within 24 hours, and all registrants will receive the email. And in addition to this weekend's virtual seminar, Dr. Lundell will be speaking in the San Francisco Bay Area on June 6th for a one-day CEU seminar in Walnut Creek. So if you're interested in that, if you live in the area, you can contact the representative Press Maycock or call our office directly to reach him. So on behalf of Biotics Research, thank you so much for spending time with us today, and we look forward to seeing you at our next Wellness Work webinar. Thank you.
Thank you, everybody. Bye.
Bye.